We'll be breaking down all major concepts covered on the exam.
Exactly.
But before we get into the heavy pathophysiology, I want you to imagine a patient sitting right there in your clinic.
Okay, let's hear it.
So they're complaining of, like, adult onset asthma, severe erosion on their back molars, and a chronic cough that just keeps them up at night.
Right, but their chest x-ray is probably totally clear. Yeah.
Exactly. Totally clear. What if I told you the culprit wasn't in their lungs or their mouth at all, but, it's actually starting deep down in their stomach?
It's a classic setup.
Yeah. If you are a Canadian medical student prepping for the MCCQE, you are going to see clinical puzzles exactly like this one.
Absolutely.
As reviewers dedicated to getting you through this test, our goal today is to make you feel, well, completely fluent in gastroenterology when you sit down for the exam.
And to give you the most accurate, high-yield foundation possible, we need to explicitly acknowledge that this deep dive teaches directly from reliable StatPearls articles. We are zeroing in on section S04 today, so specifically focusing on the pathology of the esophagus, the stomach, and the duodenum.
Basically, the upper GI tract.
Yeah, exactly. We want to decode the classic presentations, the diagnostic pathways, and, those notoriously tricky exam traps.
Oh, the traps. But a quick required disclaimer before we launch in. This is medical education only, not medical advice. And clinical decisions should involve a qualified healthcare provider.
Perfect. So let's get into it.
Right. So let's look at the gastrointestinal tract not just as a list of diseases, but like an anatomical journey.
I like that. Top down.
Yeah. We begin at the esophagogastric junction. I always picture the lower esophageal sphincter, the LES, as like a bouncer at a nightclub.
That's a great analogy.
Right. Because most of the time it does a stellar job keeping the riffraff, meaning, gastric acid and pepsin, down in the stomach where it belongs.
Right. Out of the club.
Exactly. But in gastroesophageal reflux disease, or GERD, that bouncer gets incredibly lax.
Yeah, and the physiological equivalent of that lax bouncer is a phenomenon called transient lower esophageal sphincter relaxations.
That's a mouthful.
It is. I mean, normally when you swallow, the LES is supposed to relax just to let food pass, right?
Right.
But in GRD, the sphincter relaxes frequently and spontaneously, completely independent of swallowing.
Just opening the doors for no reason.
Exactly. And because the pressure inside the stomach is higher than the pressure in the esophagus, acidic contents just wash freely backward.
And isn't that barrier failure often compounded by a hiatal hernia?
Oh, absolutely. That's where part of the stomach pushes up through the diaphragm, which physically disrupts the anatomical pinch that normally supports that sphincter.
Okay, so that structural failure leads directly back to our opening clinical puzzle.
The asthma and the cough.
Yeah. I mean, the classic presentation of GRD is obviously heartburn and regurgitation.
Right.
But the MCCQE really tests your ability to recognize those atypical extraesophageal symptoms.
Because the reflux acid doesn't just stay in the lower esophagus.
Exactly. It can travel high enough to irritate the vocal cords, causing hoarseness. It can bathe the teeth, dissolving enamel.
Dentists catch all the time.
Right. And it can even be microaspirated into the lungs, triggering bronchospasm or, stimulate a vagal reflex that manifests as a chronic, unexplained cough.
Or that adult onset asthma you mentioned.
Yeah. So for the exam, if a patient comes in with classic heartburn, do we scope them immediately or just give them medication?
Okay, exam writers will definitely tempt you with an immediate endoscopy here. Do not select it.
Good to know.
Yeah, if there are no red flags, the only correct next step for the MCCQE is initiating an 8-week empiric trial of a proton pump inhibitor, a PPI.
Got it. So you save the endoscopy, the EGD, strictly for patients presenting with alarm symptoms.
Precisely. You need to scan the clinical vignette for things like dysphagia, odonophagia, unintentional weight loss.
Basically any signs of GI bleeding like melena or unexplained anemia, right?
Yeah, exactly. If you see those, you scope.
But what if the patient just has that stubborn cough and you need to, definitively prove that silent reflux is the cause?
Well, then you look for ambulatory pH monitoring.
Oh, okay.
Yeah, this is the gold standard for medically refractory cases, or those atypical presentations.
How does that work exactly?
Basically, a catheter or a wireless capsule sits in the distal esophagus and measures the pH over, 24 to 48 hours.
Wow, so it's a direct measurement.
Yeah, it lets you objectively correlate the precise moments the patient coughs with episodes of pathological acid exposure.
Okay, so GERD represents a leaky valve. But let's reverse the physics for a second.
Okay.
What if the sphincter is tightly closed, But the stomach faces a sudden, violent, explosive spike in internal pressure.
Like during forceful vomiting.
Yeah, forceful vomiting or severe retching.
Well, then the pressure overpowers the tissue itself, leading to a barogenic injury. We call this Boerhaave syndrome.
That's the catastrophic one, right?
It really is. It's a full-thickness transmural rupture of the esophageal wall. Yeah. It usually tears at the weakest anatomical point, which happens to be the left posterolateral aspect of the distal esophagus.
And we have to clinically distinguish this from a Mallory-Weiss tear,
Yep,
right?
absolutely. That's a huge exam point. A Mallory-Weiss tear is also caused by vomiting, but it's merely a partial thickness mucosal tear.
Which usually just presents with, like, self-limiting hematomesis, right? Just throwing up some blood.
Exactly. Boerhaave, on the other hand, blasts a hole straight through the wall and into the mediastinum.
The clinical presentation for Boerhaave is just unforgettable once you understand the anatomy.
Yeah, the MCCQE will almost always guide you toward the macular triad.
Right. So first, a history of forceful vomiting.
Yep.
Second, sudden onset, severe lower thoracic pain.
And the third?
Subcutaneous emphysema.
Yes. Because when air is pushed through that transmural tear, it doesn't just stay in the chest cavity.
It travels, right?
Yeah, it travels up along the continuous fascial planes from the mediastinum all the way up into the neck.
It's so wild. When you palpate the patient's skin, it feels and sounds exactly like popping bubble wrap.
It really does. You might also hear the Hammond sign.
Wait, what's that again?
It's this distinct crunching sound over the heart that actually synchronizes with the patient's heartbeat.
Oh, because the heart is beating against that air-filled tissue.
Exactly. Now, if we suspect this rupture, an upper endoscopy makes sense to look at it, right?
No, absolutely not. Endoscopy is completely contraindicated.
Correct. Why is that?
Well, pumping air into the esophagus to inflate it for the camera would just turn a localized tear into a total disaster.
Right.
You would actively blast more air, stomach acid, and oral bacteria straight through the hole, accelerating a deadly mediastinitis.
So true. To safely diagnose it, the exam answer is a CT scan of the chest and abdomen or a contrast esophagogram.
But the critical detail here is the choice of contrast, isn't it?
Yes. You must use a water-soluble contrast agent like gastrographin as your very first step.
Because barium is strictly forbidden initially.
Right. If barium leaks out of the esophagus into the mediastinal cavity, it provokes the severe, permanent, fibrotic inflammatory reaction.
While gastrographin is just safely reabsorbed by the body if it leaks.
Exactly. Only if the water-soluble study is negative, but your clinical suspicion is still really high, can you carefully proceed to a barium study.
Just to get better mucosal detail.
All right.
And once diagnosed, I mean, this is a race against the clock.
Oh, definitely. The management strategy is aggressive and immediate.
The patient is NPO, right?
Right.
Strictly nothing by mouth.
Yes. You start broad-spectrum IV antibiotics, do massive volume resuscitation, and urgently consult surgery.
Because a primary surgical repair needs to happen within the first 12 to 24 hours.
Otherwise, the mortality rate of an untreated esophageal rupture approaches 100%.
Just incredibly dangerous.
Oh.
Okay, so moving down the GI tract, the narrative kind of shifts.
Right, into the stomach.
Yeah. The esophagus gets destroyed by acid because it lacks defensive mechanisms.
Yeah.
But the stomach and the duodenum are explicitly built to handle a highly acidic environment.
Right, they're designed for it.
So pathology here, specifically peptic ulcer disease, occurs when the aggressive forces of acid and pepsin overpower those mucosal defenses.
Mainly the mucus bicarbonate barrier, the tight cellular junctions, and that rich mucosal blood flow driven by prostaglandins.
And for the boards, the destruction of those defenses usually comes down to two major culprits.
Let me guess. The first is H. pylori.
You got it. Helicobacter pylori. This gram-negative bacterium is an absolute survivalist.
It really is. It burrows deep into the gastric mucosa and secretes urease.
Right, which converts urea into ammonia and carbon dioxide.
Effectively creating this protective alkaline cloud around the bacteria that just neutralizes the stomach acid around it.
It survives completely comfortably while causing this chronic, smoldering inflammation that just damages the tissue.
And it's responsible for the vast majority of duodenal and gastric ulcers.
Yeah. The second major culprit is, of course, NSAIDs.
Non-steroidal anti-inflammatory drugs.
Because they inhibit the COX-1 enzyme, which synthesizes those protective prostaglandins.
Right, so when you knock out prostaglandins, you drastically reduce mucus production, you halt bicarbonate secretion, and you decrease that critical blood flow.
Without that shield, baseline stomach acid just eats right past the muscularis mucosa, excavating an ulcer.
So a high-yield diagnostic skill for the MCCQE is differentiating a gastric ulcer from a duodenal ulcer based entirely on the timeline of the patient's pain.
Yes, the classic timeline.
The vignette will describe a patient with a gastric ulcer whose pain spikes 15 to 30 minutes after eating a meal.
Because eating hurts, they develop a fear of food and actually present with weight loss.
Conversely, a patient with a duodenal ulcer experiences pain 2 to 3 hours after a meal.
Or they wake up with this gnawing pain in the middle of the night.
Yeah. Eating food actually brings them temporary relief, so they often present with weight gain.
Let's dig into the physiology here. Why exactly does eating make a duodenal ulcer feel better, but a gastric ulcer feel worse?
Well, it comes down to the mechanics of digestion and the pyloric sphincter.
Okay, break that down.
When you eat, the physical stretching of the stomach walls and the presence of proteins trigger a massive surge in gastric acid secretion.
Right, turning on the acid pumps.
If you have an open ulcer in the stomach lining, that fresh, highly acidic wash hits the raw nerve endings almost immediately.
That perfectly explains the rapid onset of pain in a gastric ulcer.
Exactly.
But while that stomach is churning, the pyloric sphincter, the valve separating the stomach from the duodenum, is clamped tightly shut to hold the food in.
Yes. The duodenum is temporarily isolated from all that new acid.
Ah, okay.
Furthermore, the food sitting in the stomach acts as a powerful buffer, physically soaking up the hydrogen ions.
So the duodenal ulcer gets a reprieve and the pain subsides.
Exactly. However, 2 to 3 hours later, the stomach finishes its job. The pyloric sphincter opens, and an entire load of highly acidic chyme is dumped directly into the empty duodenum,
washing mercilessly over the ulcer. Ouch! And at night, when the stomach is empty, basal acid secretion just continues to drip down and pool in the duodenum without any food present to buffer it.
Which perfectly explains the classic 2 a.m. wake-up call for duodenal ulcer patients.
So to manage this, you obviously stop the NSAIDs.
Yeah, and if a urea breath test or stool antigen confirms H. pylori, you deploy a triple therapy.
The standard regimen is a PPI, clarithromycin, and either amoxicillin or metronidazole, right? For 7 to 14 days.
That's the one. The PPI raises the gastric pH, which actually allows the antibiotics to function optimally.
Well, clarithromycin halts bacterial protein synthesis, and amoxicillin destroys the bacterial cell wall.
But we have to consider the outliers. What if a patient is doing everything right? No NSAIDs, no H. pylori, but they keep getting recurrent, multiple ulcers.
Especially in weird spots like the distal duodenum or even the jejunum.
Right. That clinical picture points away from a defensive failure and straight toward an overwhelming pathological hypersecretion of acid.
We're looking at Gastrinoma or Zollinger-Ellison syndrome, ZES.
Yeah. ZES is driven by a neuroendocrine tumor autonomously pumping massive quantities of gastrin into the bloodstream.
And gastrin relentlessly stimulates the parietal cells in the stomach to just produce hydrochloric acid.
The resulting environment completely overwhelms the neutralizing capacity of the entire upper GI tract.
You typically find these tumors hiding within the gastrinoma triangle, right?
Yes. That's an anatomical zone bordered by the cystic and common bile duct, the second and third portions of the duodenum, and the neck and body of the pancreas.
The board examiners have a favorite trap for ZES.
Oh, the diarrhea one.
Yeah. They will present a patient with severe peptic ulcer disease accompanied by chronic voluminous secretory diarrhea.
And strangely, the diarrhea completely resolves when the patient is placed on a high-dose PPI.
The mechanism linking stomach acid to diarrhea is so fascinating.
It really is. The sheer volume of highly concentrated acid dumping into the small intestine physically damages the delicate intestinal villi,
impairing the absorption of sodium and water.
More importantly, pancreatic enzymes, which we need to break down fats, can only function in a neutral or slightly alkaline pH.
So the extreme acidity of ZES completely denatures them.
Exactly. It permanently inactivates enzymes like pancreatic lipase.
Without functioning lipase, the patient cannot digest dietary fats, resulting in severe malabsorption and steatorrhea.
But by administering a massive dose of a PPI, you shut off the acid source.
The intestinal pH normalizes, the pancreatic enzymes reactivate, and the diarrhea just vanishes.
Right. But when you diagnose ZES, your work isn't done. You must evaluate the patient for MENN1 syndrome, multiple endocrine neoplasia type 1.
Because up to 30% of ZES cases are linked to this genetic mutation.
Exactly. So you check for the other classic manifestations: parathyroid hyperplasia, checking serum calcium and PTH levels.
And pituitary adenomas, which you screen for via prolactin levels.
Confirming the gastrinoma itself starts with a fasting serum gastrin level, which will be, well, profoundly elevated.
And if the levels are equivocal,
then you utilize the secretin stimulation test.
Okay, because physiologically, the hormone secretin is supposed to inhibit gastrin release.
Right. But gastrinoma tumor cells possess abnormal secretin receptors.
So when you administer exogenous secretin, it paradoxically triggers a massive spike in gastrin release.
Exactly. Once confirmed, management dictates ultra-high-dose PPI therapy, and if the tumor is localized, complete surgical resection.
Wow. Okay, so those are the acute and hypersecretory pathologies.
Right.
Now we have to examine the grim end-stage consequences of chronic, unrelenting mucosal inflammation.
Over years or decades, constant damage leads to cellular atrophy, metaplasia, and ultimately gastric cancer.
This requires a deep understanding of atrophic gastritis. The MCCQE expects you to differentiate the two major variants.
Autoimmune metaplastic atrophic gastritis, or AMAG.
And multifocal atrophic gastritis.
No, let's start with AMAG. It's a targeted autoimmune destruction.
Right. The body generates autoantibodies directed against its own parietal cells and intrinsic factor.
And since parietal cells are predominantly clustered in the body and the fundus of the stomach, the inflammation is strictly confined to the upper portions of the stomach,
leaving the lower antrum completely spared.
Exactly.
But the destruction of parietal cells triggers a dual crisis. First, the patient develops achlorhydria, a total lack of stomach acid.
And second, and far more clinically apparent, is the loss of intrinsic factor,
which is absolutely mandatory for the absorption of vitamin B12 in the terminal ileum.
Right. Without it, the patient develops pernicious anemia.
You will see macrocytic red blood cells on a smear, and the patient may report severe neurological deficits,
like peripheral neuropathy or subacute combined degeneration of the spinal cord.
All due to that B12 deficiency. Now, multifocal atrophic gastritis, MAG, operates entirely differently.
Right. MAG is an environmental pathology driven by decades of chronic H. pylori infection.
Unlike the autoimmune variant, H. pylori typically establishes its stronghold in the antrum of the stomach.
And over time, that chronic inflammatory front slowly marches upward into the body of the stomach, obliterating the native gastric glands.
When the native gastric cells are eradicated by this toxic environment, the body attempts a desperate repair.
But instead of regenerating gastric mucosa, it replaces the dead tissue with intestinal-type cells.
Right. I always think of this intestinal metaplasia like squatters moving into an abandoned building.
That's a really good way to visualize it.
The original tenants, the acid-producing cells, were evicted by inflammation. So disorganized intestinal cells move in to occupy the empty space.
And because they are residing in a completely inappropriate environment, they are highly genetically unstable,
carrying a massive risk of mutating into dysplasia and cancer.
Exactly. Now, to detect this atrophy non-invasively, we look at serum pepsinogen levels.
Okay.
The chief cells in the gastric glands secrete pepsinogen 1. As the glands are destroyed, pepsinogen 1 levels plummet,
leading to a drastically reduced pepsinogen 1 to pepsinogen 2 ratio.
Right. This lab finding is a glaring biomarker for advanced gastric atrophy.
Endoscopy is required at this stage, obviously, but visual inspection alone isn't enough.
No, you must employ the Sydney protocol,
taking multiple specific mapping biopsies from the antrum, the corpus, and crucially, the incisura angularis.
Yeah, the incisura angularis is the notch on the lesser curvature of the stomach where the antrum meets the body.
This transitional zone is precisely where H. pylori-driven inflammation is often most intense.
And where metaplastic changes frequently begin.
If that unstable metaplasia crosses the threshold into malignancy, we evaluate it using the Lauren classification.
Right, which divides gastric cancer into intestinal type and diffuse type.
The intestinal type represents the culmination of the process we just mapped out, right?
Yeah. H. pylori infection progresses to atrophy, then to intestinal metaplasia, dysplasia, and finally a distinct, cohesive, gland-forming tumor mass.
The diffuse type, however, is a biological nightmare.
It really is. These tumor cells often have a mutation resulting in the loss of E-cadherin,
which is the crucial intercellular glue that holds epithelial cells together.
Because they lack adhesion molecules, they don't form a solid mass. Individual cells aggressively and diffusely infiltrate the entire submucosal layer of the stomach.
Under the microscope, these are the infamous signet ring cells.
Yes. The cell produces a massive vacuole of mucin that physically pushes the nucleus flat against the outer cell membrane.
Literally looking exactly like a signet ring.
And as these cells infiltrate and proliferate within the submucosa, they trigger an intense fibrotic reaction.
The stomach wall thickens, loses all elasticity, and becomes completely rigid.
On imaging, the stomach cannot distend with air or fluid at all. It looks like a stiff leather pouch.
This is linitis plastica.
Exactly.
Now, how do these patients usually present to the clinic? The presentation involves some of the most tragic exam traps.
Unfortunately, yeah. Symptoms like early satiety, vague upper abdominal discomfort, and unexplained weight loss are notoriously late indicators.
By the time a patient with linitis plastica feels full after just 3 bites of food because their rigid stomach cannot expand, the cancer is usually already disseminated.
For the MCCQE, you must immediately recognize the physical exam eponyms that signal metastatic spread.
Right. A hard, palpable, enlarged lymph node in the left supraclavicular fossa is a Virchow node.
This occurs because the abdominal lymphatics ultimately drain upward into the thoracic duct,
which empties into the left subclavian vein, seeding the nodes in the left neck along the way.
You might also palpate a firm metastatic nodule directly at the umbilicus,
known as a Sister Mary Joseph nodule, representing aggressive peritoneal spread.
And in female patients, if an ultrasound reveals bilateral solid ovarian masses alongside weight loss and vague gastric symptoms, you are looking at Krukenberg tumors.
This represents transcolomega spread, right?
Yes, where gastric cancer cells shed into the peritoneal cavity and follow gravity down to implant directly onto the surface of the ovaries,
often bringing those distinct signet ring cells with them.
The prognosis at that advanced stage is exceptionally poor.
But if gastric cancer is caught early enough to be curable, the gold standard diagnostic tool is an upper endoscopy with multiple biopsies.
And management involves surgical resection, a partial or total gastrectomy.
Crucially, the surgeon must perform a D2 lymphadenectomy.
Right, removing not just the lymph nodes immediately adjacent to the stomach, but the second tier of nodes surrounding the celiac axis and its branches.
This extensive clearance is mandatory because it significantly reduces the rate of locoregional cancer recurrence.
Usually supported by perioperative chemotherapy.
Wow. We have journeyed through a massive amount of high-yield physiology today.
We really covered a lot of ground.
We started at the esophageal junction, exploring the lax bouncer of GER, and identifying the critical threshold for using PPIs versus scoping for alarm symptoms.
We reversed the pressure to examine the devastating transmural blowout of Boerhaave syndrome, tracking the escaping air up the fascial planes and prioritizing gastrographin over barium.
We moved into the acid landscape of the stomach, mapping how the pyloric sphincter dictates the postprandial pain of gastric ulcers versus the delayed pain of duodenal ulcers.
We dissected the molecular synergy of triple therapy for H. pylori and untangled the complex interplay of gastrin, deactivated pancreatic lipase, and secretory diarrhea in ZES.
Finally, we traced the silent, destructive march of chronic inflammation. We differentiated the B12 depleting autoimmune attack of AMAG from the H. pylori-driven intestinal metaplasia of MAG.
And we explored how the loss of cellular adhesion leads to the creeping leather bottle infiltration of diffuse gastric cancer,
often revealing its silent spread through a Virchow node or a Krukenberg tumor.
As medical students and future physicians, mastering these pathological mechanisms isn't merely an exercise in passing the boards.
Not at all.
When you realize that a patient's worsening asthma is actually a vagal reflex triggered by silent acid reflux, or when you order a pepsinogen ratio to catch atrophic gastritis before it transforms into an incurable linitis plastica, you are using this exact physiology to alter the trajectory of a patient's life.
That's incredibly well said. I want to leave you with a final thought to mull over as you continue your clinical training.
What's that?
Well, our entire modern approach to the upper GI tract revolves around neutralizing acid. We utilize triple therapy to eradicate H. pylori, and we hand out potent, lifelong proton pump inhibitors for GERD and hypersecretion.
Right, it's our go-to tool.
But stomach acid evolved for a reason, to sterilize the food we eat and break down complex nutrients.
That's true.
As we aggressively and permanently alter the stomach's pH, we are fundamentally reshaping the human microbiome, risking severe enteric infections, and impairing the absorption of vital minerals like calcium and iron.
It's a huge trade-off.
Exactly. The medical community is just beginning to confront a vital question. What are the true long-term systemic consequences when we permanently turn off human acid?
It's a fascinating area of ongoing research.
Keep asking those difficult questions, keep connecting the physiological dots, and trust your preparation. You are going to do exceptionally well on this exam.